just tell me because I can talk anytime. Okay, so we're going to talk today a little bit about pediatric physical therapy for bowel and bladder issues. I get a lot of questions from people that ask, you know, what can physical therapy do? You know, they can run and jump and play fine, but what can you do for bowel and bladder issues? And a lot of people don't actually come in the door because they don't understand what we can do for bowel and bladder issues. So I want to talk a little bit about that today. Let's see. Helps if I know which one I'm doing. Okay, how PT can help. So we look at muscle coordination and posture. When a child is constipated, and I'll have a slide here in a minute showing anatomy, but the bowel goes like this in the body. And if this side is packed with feces and then into the pelvis is packed with feces, the body can't rotate. It can't integrate reflexes. It can't become coordinated in many aspects. So just getting rid of the constipation and understanding the impact that that has on pediatric development throughout the lifespan is very, very important. It's very physical therapy related. Breathing and mechanics. A child that is full of feces also, or has urinary incontinence, is upregulated a lot, so like they're really hyper, they're always anxious, those kinds of things. That diaphragm that goes in here can't plunge like it's supposed to, which impacts motility, and it also impacts their ability to breathe, keep up with peers, those kinds of things. So we look at those things as well. Nervous system and regulation. There's a nerve that goes from in the pelvis all the way up to the brain called the vagal nerve, and that impacts that brain-gut connection. If that isn't able to regulate well, that impacts their ability to settle themselves, to rest and digest, or fight or flight. They kind of maintain that fight or flight nervous system. We work with that. Primitive reflex education and treatment. So a child that is a baby typically integrates asymmetric tonic neck reflex, symmetric tonic neck reflex, galant, moro. There's a lot of reflexes that integrate when they're young, that if you're constipated and you can't dissociate these things or these things, then you don't integrate those reflexes. So like the moro reflex, for example, that scary thing when they go backwards and extend their head, leads to more like outburst behaviorally, some other impacts there, and inability to sit in school. They get ADHD diagnoses, things like that. So we look at the impact of constipation, fecal management, urinary continence management relative to those things. Water balance. If a child isn't drinking enough water, if they're not voiding enough water, if the water's being taken out of the bowel instead of being utilized when they ingest it, we look at those things. Diet modifications. So there are some things like dairy intake, irritant intake, as far as like the bladder's ability to understand what it's supposed to do. We look at those things. Interoception, which is kind of a new paradigm that we're talking about, like the seventh sense. So your body's ability to understand what it's feeling and being able to react to those things. We work a lot with kids who are like addicted to electronics, who their focus is outside of their body the majority of the time, so they're ignoring the body signals. They're not aware of those things, so they're losing the ability to understand when, where, and how to have a void, that they have to have a void, those things. And then pressure management. So we get a lot of kids when their abdominal cavity is full, whether it be bladder or bowel, pressure is pressure. They only feel pressure, so they don't understand how to manage that, how to direct it toward their bottoms in order to void. They don't understand how to relax their pelvic floor in order to allow urine to come out or allow feces to come out and direct the abdominal pressure toward the bottom. So we work with all of those things. So it takes muscles to pee and poop. So when we look at the pelvic floor muscle, we look at range of motion and resting position. So in a pelvis, let me take these out real quick. In a pelvis, there are muscles here. This is a female pelvis. There are muscles here and muscles inside, as well as muscles here that help with the breathing. If you're elevated and holding because you have a lot of pressure inside here, or a lot of feces inside here, a lot of weight, then those muscles elevate to hold. Well, that becomes a dysfunctional position. So like the kid can't open and allow because they don't have the range of motion. They can't pull up and in because they can't hold. They only have that static resting posture. The other thing is there's a sphincter, which is a muscle that kind of pinches your tube shut as far as your rectum is concerned, internal and external sphincter. If the internal sphincter is weighted with stool, it will open and that will become the new resting position. So that can become open. The child has no idea that it's open. And then feces will leak out of the bottom because this muscle just gets desensitized. So it's kind of like a Band-Aid is what I tell patients. If you put a Band-Aid on, you know it's there for a minute, pretty soon you don't realize it's there. It's the same with fecal material. If feces is there for a minute, you might realize it, but pretty soon it becomes normal and you don't understand that it's there. That's one of the biggest things I try to explain to patients who leak feces is that that child really truly doesn't understand that it's coming out. So those things are very important. Can the child activate or relax those muscles? Do they have any awareness of those muscles? Can they pull them up and in? Can they relax them and bulge? Do they have the range of motion available? We work with those things. Are the muscles working with each other? So a lot of kids who have learned to walk, or they run, or they're in gymnastics, or whatever it might be, this tailbone anchors those muscles. If this tailbone dislocates or becomes internally dislocated, or it breaks, or they land on it several times and they don't really realize it, then these muscles might not work symmetrically. So I'll get kids with like lots of tenderness around their bottom here. I'll get kids with tenderness around their bottom here, or like one side will bulge and it's great, the other side does nothing. So the bowel isn't allowed to allow that stool to come out. So those things we work on as well. Tummy muscles, are they holding, fighting, or blowing forward? So we have kids that when they bear down trying to have stool, they'll blow their tummies forward because it just feels like pressure is pressure is pressure, instead of being able to contract those muscles and direct it down toward the bottom. So we'll work with coordination regarding that. Diaphragm muscle and intercostal muscles. So when you look at a pelvis like this and a diaphragm here, that works so the diaphragm can come down, the intercostals, which are the muscles between the rib cage, brings that pressure in, the obliques, which come into the abdomen, contract, all of that regulates pressure. If the child doesn't have the ability to understand those muscles and how they're supposed to function, we work with that coordination. A lot of kids that have a lot of pressure in here blow their tummies out and forward when they're trying to push, which it's effort, yes, but it's not directed effort. It's not management of the pressure. And then a lot of those kids also are straining. So these muscles are really tight, their legs get really tight. Some of them even stand in extension in order to poop. They work those muscles until the bottom fatigues and then the stool will come out. But that's not a functional way to do it, and it doesn't allow all the stool to come out. So we work with a lot of those kind of coordinated muscles in order to make the voiding happen. So what we look at with muscles, pelvic floor, are they elevated or resting in a loose posture? Most of the time with a pediatric patient, they're elevated. They'll be up and in because they're holding the weight of the stool and the urine. Do both sides move the same? So we're talking about like that asymmetry like we were talking about a minute ago. Is the tailbone in place? Now we can relocate that tailbone, and typically we'll use some kind of external pressure management in order to get that, or I'll teach them exercises in order to get that tailbone to come out. We don't have to do anything crazy. Is there pain with palpations? So when I go in to touch their bottoms to see how it moves, is there pain relative to me being able to push those muscles? Abdominal, is the tummy poking out? Does the child have a diastasis? And a diastasis is really a lot of times people think of like pregnant women. So where their abdominal component right here separates, those muscles separate because they've been bearing down. A child with constipation or somebody that's really dysfunctional in how they void will end up with that diastasis, and you'll see that component and the internal contents come out of the abdomen. So, and it'll bulge out forward. And so we know that child isn't managing their pressure well, and that we need to address that. The diaphragm, is it flattened or is it utilized well with breathing? So a child with constipation, a lot of times that fecal material comes up underneath the rib cage, and you'll see an asymmetry, like these ribs will come out this way, and then the rib cage will come out like this, and then this becomes a flattened arc. So like with children, this arc is 80 to 90 degrees is normal. Most of the kids that I see with constipation are well over 100 to 150 degrees of an arc. So their diaphragm is very flat. That impacts its ability to plunge and assist with motility. So we work a lot in that area. Rib cage and intercostals, are they overcompensating or not being utilized? So when you look at a child with lots of constipation and we have that flattened rib angle, a lot of kids breathe up here in those upper rib cage. So they're not even using that diaphragm really to bring air into their bodies. And then they end up with like that barreled chest, like an asthmatic almost, that looks very, very large up here. And they're most of the time a mouth breather, because that's the only way to create enough negative pressure to bring air into the lungs. These kids also wear out very quickly when they're running and jumping and playing with their peers. So what the muscles look like. So I wanted to bring up some anatomy just so that we can kind of see it more so than this. So when we look at anatomy, this is a back. So here's the anus, and these muscles sling around here around that tailbone. So the tailbone's integral to the ability to have a good functional stool. We work with those muscles. You also see how the hips and those muscles align in with the ability to utilize that pelvic floor. So we look at that. I look a lot at range of motion, hip ability to rotate in, rotate out, up, down, all of those things. That also impacts that child's ability to run coordinated. So we look at that. From the inside, so looking internal, so here's the pubic crest, or the iliac crest here. So that would be this component of the muscle, and then here's the spine. You can see how some of the muscles go up into the back. Now there's another set also that comes up into the lower back. Those muscles are very, very important in order to allow for feces to line up with the colon and allow it to allow them to excrete feces. So that's very important. You can also see a little bit of the diaphragm. I've got it up here, more of the diaphragm. That this ability to move up and down directly impacts the pelvic floor. So we look very closely at those muscles in order to make sure that that child is coordinated enough to actually void urine and feces and manage those things so that they can develop normally, run, jump, play, and do those things in coordination. So I have a little video here. This is a very constipated young man, and you'll notice that he waddles back and forth rather than reciprocates his legs. Like he'll walk one leg in front of the other. But un momento. Okay. So you see how that lateral movement goes, and you can see his tummy, his large abdomen there, his flattened rib angle. So that's very typical of a kid with constipation. This is another picture. This was taken 2 weeks apart, which is hard to believe. So this child I saw with constipation, you can see flattened abdomen. We see a little bit of protrusion of belly. You can see his lateral weight shifting when he's running. 2 weeks later, after he's resolved his constipation, we see no more abdomen protrusion. We see reciprocation and trunk and shoulder dissociation. I mean, 2 weeks, that's amazing. in his level of ability to run, jump, and play. And mom, even after she sent these pictures, was like, this is crazy that he's able to function and keep up with other kids now. Here, he was taking multiple breaks. And then here, he was keeping up and leading the pack. So it's amazing the difference in kiddos. Another thing is posture. So when a child walks in to therapy, I'm first and foremost looking at, like, what's the pelvis look like? What's the lumbar spine looks like? You know, what does their chest look like? How do they sit? Standing posture, you know, where are the pelvis, hips, spine, chest, and ribs? So on a lot of kids, this is a pretty normal, it's an adult, but it's pretty normal for a child too, where you have this little bit of lumbar spine curve, and then it kind of comes up into a thoracic curve. On a child with lots of constipation, you'll see this flatten. This will posteriorly rotate. They will become sacral sitters. Their chest and pelvis are not elongated. It's very short. So those short, those kids that look like they have a really short torso, a lot of times may have some constipation. It may also be, you know, positional from family or positional from sitting and doing something for a long time, but a lot of my constipation kids, I see that. So sitting, we're kind of looking at the same thing. When they're sitting on the toilet, we do a lot of postural education. Are they relaxed? Are they tense? Are they able to sit? Many of the kids that come in who have urine and fecal leakage, they're very much in an extension, or they cross their legs, they go in a corner, or they hide in order to have a bowel movement or urinate. And so we do a lot of education with the family. Like, if you see them doing those things, we promote other postures in order to help them get better. Like, starting just with, like, can they do it in the bathroom? You can go stand in a corner in the bathroom. So we get more like a behavioral change in location first, and then we work on positional changes while the child is in there. The other thing that we work on with sitting on the toilet is, can they separate their legs from their torso? So can they keep their legs and their bottom soft and relaxed, allowing the feces or urine to come out, and allow the tummy to work like it's supposed to directionally add pressure, particularly if it's feces. If it's urine, we want the whole body to relax and allow the urine to come out. So there's some things that we teach there in posture. Breathing. What do we look at with breathing? So what part of the chest, I kind of touched on that a minute ago, is the abdomen the primary, or is the upper chest the primary? So we look at those things. Is the body calm or able to get calm with breathing? Can the child make a decision to become calm? Or is it a situation where the child is always upregulated, on the move, and we have to teach them how to get there? Is their mouth open or closed? If they're not a nose breather and they're a mouth breather, then they're going to expel a whole lot more water. So we look at the water balance relative to that. Why are they doing the mouth breathing? Is it because they can't use their diaphragm and they need that increased pressure, or is it truly like a structural problem? So, you know, it takes a village, so we'll refer them out to whoever we need to. Does the child use his or her diaphragm? Are they using accessory muscles in order to breathe? And then what do the ribs look like? Are they flaring out to the side? Are they only using their rectus? You know, those kinds of things. When reflexes are present, so does the child have a difficult time sitting? So children that have like an ATNR or an STNR or a gallant where they're real ticklish, those kids, if they're not integrated with those reflexes, or only partially integrated with those reflexes, they have a really hard time sitting. You know, this is an integrated pattern to sit, to write, to do those things, to look up at the teacher and then come back to writing. If the reflexes aren't integrated, then they come off as like behavior problems. They're always moving. Their body never feels organized. So we look a lot at those things, and why is that the case? Especially if there's not been any neurological insult, they haven't had a brain injury, they don't have a stroke when they're little. All of the things that would typically have those like manifestations of primitive reflex, like why is this child having them? A lot of time it's due to bowel and bladder dysfunction. So we can work with that. What does the body do in relationship to movement of the head and pelvis. That's kind of along those same lines as the reflex integration. Is it here? Is it here? You know, if you're asking a kid to look this way and the arm is out here and you want them to right, that's an integrated pattern. So a lot of education goes into the parent, the teacher, all of those things to help that child function better while they learn to integrate those patterns. What does the nervous system do and how does it react? So if that child is always like nervous, anxious, anxiety, those kinds of things, maybe the Moro didn't integrate well. So that's a primitive reflex as well that kind of causes those kind of outlandish reactions that everybody thinks comes kind of out of the blue when it really doesn't, but you just don't understand why. So physical therapy works with those things. And then can the child interrupt the reflex? And apparently I didn't finish the rest of my sentence. So, but can he cognitively understand what's going on and say, or she, and go, okay, I need to get it together and here's my effort. Just keep in mind that it takes a lot of effort and energy to interrupt a reflex pattern, and then they at some point have to kind of let loose a little bit and expel the energy that they had to focus on in order to interrupt those patterns. What can breathing do? We work a lot with breathing. It can assist with gut motility. So kind of like we were talking over here, that diaphragm in a good position, when they breathe, impacts the ability to massage the gut and increase motility, so the gut's ability to move the stool around in their bodies. It can improve pressure management also, because you can take a breath in, hold, and direct the pressure. So we want to make sure that we can do that. Regulate the nervous system, because of that vagal nerve, that brain-gut connection, we can affect the body's ability to be calm or upregulate or control those things. So it's the parasympathetic and sympathetic nervous system. And it can also focus concentration on body signals. So breathing actually can bring awareness to what's happening here. Is the gut moving? Do you need to pee? We can teach them cues, you know, things like that, in order to help them be able to function better. So physical therapy as an overview helps with treatments in all of those areas. We help coordinate those body systems so that they can function appropriately together. And then we help bring awareness of the ability to control those things. So the child has control. We want to give them control so that they understand, I can do these things. It's not just something happening to me. It's something I can have control over. And really that's the essence of everything, is so to give that child control. Thanks so much.